Good evening, everyone, and a warm welcome to this combined SECEC and EUSSER webinar. My name is Jagwant Singh, and I am the chair of the Healthcare Delivery Committee of the European Shoulder and Elbow Society. And our webinar is focused on management of elbow instability. We have the webinar in two sessions. The session one is about management of acute elbow instability. And I'm thankful to Sara de Boey, Lee van Rensburg, Professor Adam Watts, and Tom Verhoeven for sharing their experiences on anatomy, the assessment of the acute unstable elbow, the fracture dislocations, and the rehabilitation of the elbow. The second session will be about the management of chronic elbow instability, and we are grateful to Pieter Caekebeke, Paolo Arrigoni, Professor Roger Van Riet, and Marcus Bateman for sharing their expertise in this. I would like to extend my thanks to my co-chair, Maria Valencia. She is the chair of the research and development at the European Shoulder and Elbow Society, and she's also the chair of the teaching committee of the Spanish Shoulder and Elbow Society. She coordinates the residency program in orthopedics in Madrid, and she's also an associate editor of the Shoulder International Journal. So great experience with sharing her expertise today with us here. I would like to also welcome my moderators, Alessandra Colozza. She is the chief of the orthopedics and traumatology at the Faenza Hospital, and she has numerous accolades. She is member of the Mayo Elbow Club. She teaches on multiple courses and has professorial roles at multiple universities and positions. She is reviewer of many shoulder and elbow journals, and she is also the educational chair of the Global Elbow Network. I would also like to thank my friend and colleague on the Healthcare Delivery Committee, Solenn Gain. She's the president of the EUSSER and also the vice president of the French Society of the Shoulder Physiotherapists. And she's brought all her expertise in here today to moderate the session. So thank you very much to my moderators and co-chair. And also, once again, thank you to all the speakers who have given up their time and dedication to move the field of elbow surgery forward.
Good night. Thank you for your nice introduction. So I will present our first speaker, which is Sara de Boey. She has had an extraordinary training based in Belgium, but not only that, she was also awarded the European Traveling Fellowship. So she has had the experience to travel all around Europe learning shoulder and elbow. And she's going to give our first talk that it is regarding the anatomy, bony anatomy and ligaments of the elbow. So very welcome, Sara. We are waiting for your presentation.
Good evening, everyone. Today, I will briefly guide you through the bony anatomy and the ligamentous stabilizers of the elbow as a foundation to better understand acute elbow instability, which will be addressed in the following presentations. The elbow is often described as a simple hinge joint, but in reality, it is a highly congruent and complex articulation relying on both bony and ligamentous stabilizers that work closely together. Anatomically, the elbow consists of three joints within a single capsule: the ulnohumeral joint, the radiocapitellar joint, and the proximal radioulnar joint. The first, the ulnohumeral joint, is the primary stabilizer of the elbow, providing approximately 90% of resistance against varus stress. This is due to the highly congruent articulation between the trochlea and the greater sigmoid notch of the ulna. In particular, the coronoid process acts as an important anterior buttress. The second joint within the capsula, the radiocapitellar joint, function as a secondary stabilizer, especially against valgus stress, and it contributes to the axial load transmission. And then the last, the proximal radioulnar joint, allows the forearm rotation, enabling pro and supination of the elbow. Functionally, the elbow is both a hinge and a pivot joint. It allows flexion and extension from full extension or even a hyperextension to 15 degrees to about 150 degrees of flexion. In addition, it allows 75 to 85% of pronation and 80 to 105 degrees of supination. These combined motions are essential for daily function, but it also exposes the elbow to complex loading patterns, particularly during trauma, making it vulnerable to instability. While bony congruency provides intrinsic stability, ligamentous stabilizers are essential under stress. On the medial side, we have the medial collateral ligament complex, or the MCL, a triangular structure consisting out of 3 bundles. On the lateral side, we have the lateral collateral ligament complex, or the LCL, consisting out of 4 parts. First, we're going to talk about the MCL complex. This consists out of an anterior, a posterior, and a transverse bundle. The anterior bundle is the most important component, particularly in the functional range of motion. It runs from the anterior part of the medial epicondyle to the coronoid process, the sublime tubercle. And its stabilizing role is position dependent, contributing about 1/3 of the valgus stability in extension and up to half at 90 degrees of flexion. The posterior bundle of the MCL complex runs from the posterior medial epicondyle to the medial olecranon. And we see that the anterior and the posterior bundles function reciprocally, with the anterior bundle that is tight in extension and the posterior bundle that is tight in flexion. And then the third bundle is a transverse bundle, or the Cooper ligament, and that runs from the anterior to posterior bundle on the olecranon. This has a less important role in the stability of the elbow, but it reinforces the other 2 bundles. The MCL complex acts as a primary stabilizer of the elbow during valgus stress. In addition to the valgus restraint, the MCL also limits the internal rotation and it contributes to the posteromedial rotatory stability, especially through the anterior bundle. Importantly, the MCL works together with the flexor pronatal muscles, which provide dynamic medial stability. And clinically, we can test the MCL with the valgus stress test. This is performed in 20 to 30 degrees of flexion with a forearm in pronation. Or we can do also a valgus loading or stress test in more flexion, which is called the milking test, as you can see on the image. And then we move to the lateral side. The LCL complex consists out of 4 bundles: the radial collateral ligament, the lateral ulnar collateral ligament, the annular ligament, and the accessory ligaments. The most important one from this complex is the LUCL, the lateral ulnar collateral ligament, and it runs from the lateral epicondyle to the supinator crest. It is the most important stabilizing bundle of the LCL. And then you have the second bundle, the radial collateral ligament, that runs from the lateral epicondyle to the annular ligament. The third one is the annular ligament itself that stabilizes the radial head and that allows smooth pro and supination. This ligament inserts on the lesser sigmoid notch. The fourth bundle is the accessory ligament, which runs from the annular ligament to the supinator crest and also reinforces the ligaments but plays a less important stabilizing role. The lateral ulnar collateral ligament, or the LUCL, is the primary stabilizer against the posterolateral rotatory instability, or PLRI, and this is the most common instability pattern after elbow trauma. Disruption of the LUCL can lead to posterolateral rotatory subluxation characterized by external rotation of the forearm relatively to the humerus. The LCL complex mainly provides the rotatory stability and contributes to the varus stability to a lesser extent, approximately 10%. The instability we see is the most pronounced in supination, which is clinically important. And the dynamic stability is supported by the extensor muscles, with the anconeus acting as a key dynamic stabilizer against both varus stress and the PLRI. Clinically, the LUCL injury can be assessed using the lateral pivot shift test, which is performed with the patient in supine position. You apply axial compression and valgus stress with the former in supination. To conclude, elbow stability depends on a delicate balance between the bony congruency, particularly the ulnohumeral joint with the coronoid process as primary stabilizer against the varus stress, the medial ligamentous support resisting the valgus stress, and third, the lateral ligamentous support, especially the LUCL, preventing the posterolateral rotatory instability. When this balance is disrupted, instability occurs in a predictable sequence involving both ligamentous and bony structures, and this forms the basis for understanding the acute elbow instability, which will be further explored in the next presentations. Thank you for your attention.
Thank you, Sara. Very interesting presentation. The knowledge of anatomy and biomechanics is mandatory to understand the instability of the elbow. So it's my pleasure to introduce Dr. Lee van Rensburg. Dr. Lee van Rensburg trained in South Africa, then he moved to UK. He's working as a brilliant upper limb surgeon. He's very smart, you will see, in the hospital of Addenbrooke's. It's a part of Cambridge Hospital, and in the Spark Cambridge Lea Hospital and Northfield Hospital. Lee, do you want to share your experience about assessing the acutely unstable elbow?
Great. Thank you for the invitation. My disclosure is I've never done a milking arm test. I've never done a posterolateral jaw test to assess a patient who has acute elbow instability. The treatment for elbow instability is movement of the elbow. Movement of the elbow makes the elbow more stable. And I think when you get an acutely dislocated elbow, they come in three groups. There's one that is clearly stable. You take the back slab off the patient and the patient immediately starts moving their elbow, and you know that's not going to be a problem. There's another patient, you take the back slab off and the arm is swollen and bruised. They've got immense pain in their arm. They had a lot of immense pain at the time. And the elbow is completely subluxed on all the imaging you've seen, and that elbow is not safe to move. And occasionally there's one in the middle where you're not sure. Is this elbow safe to move? Isn't it safe to move? Well, part of the answer comes on the story. So we used to get told the story by patients. Now we get shown the story by patients. This is Caekebeke. He puts his hand down in supination of the valgus force across his elbow and sustains a posterolateral dislocation of the elbow. The classic dimpling that you might associate with PLRI, but there's no doubt in my mind that this elbow dislocated with a pure valgus force. This is wrestler Boey. He puts his hand down, pops his MCL, and you know he's dislocated his elbow, but it's reduced itself. You don't need an MRI to tell you that he's popped his MCL. There's no way your MRI stretches that far. And when he gets his plane radiographs, you see it's normal. Here we see weightlifter. Hand is in pronation now. Immense axial load and valgus stress. And he tears everything on the medial side. I'd be very surprised if that elbow is going to be remaining stable and safe to move, but you can't be 100% sure. This is Ronda Rousey, the arm collector. She PLRIs this elbow. She doesn't pop the MCL, I don't think. She hyperextends her hips, supinates that hand, and just pivots the capitellum off the back of the radial head. And so part of your story comes from the patient. It doesn't really matter whether you go medial to lateral, reverse hori, or whether you go lateral to medial. What matters is that elbow safe to move? The next thing that people jump to is they jump to the MRI. And the problem with MRIs is they make everything look bad. You find it looks like a bomb's gone off in the elbow. This is Wrestler Boy. This isn't actually his x-rays, but this is what his x-rays would look like. A perfectly reduced ulnar-humeral joint, and on the lateral, a reduced ulnar-humeral joint. But on that soft tissue shadow on that medial side, you can see the soft tissue swelling. You take the back slab off, and it looks like a bomb's gone off in this person's arm. And you go, I think a bomb might have gone off in this arm, and so I get an MRI. And surprise, surprise, it looks like a bomb has gone off. But the great news for this patient is that it started on the medial side, so reverse hori, it's got almost to the midline, but you see there's not a lot of signal there on that lateral side. So this elbow is probably safe to move. Okay. So the problem with MRIs is there's too much signal. So there are some. Barn door, really simple dislocation, elbow's perfectly reduced, hasn't gone far. This is a subluxed elbow. This is the PLRI elbow. This is Ronda Rousey's, not hers, but her opponent's elbow. She's just pivoted that radial head off the back of that capitellum. Sean O'Driscoll's classification of PLRI. So it's there, perched, subluxed. Next elbow dislocation. It's gone a little bit further. This is probably Wrestler Boy, but the humerus is well opposed to the ulnar. And the post-reduction films are absolutely perfectly congruent. And you take the back slab off and you get that elbow moving, and it just gets moving. He kicks out some HO, and I couldn't quite explain why he kicked out his HO. We now come to this elbow here. And this elbow tells you its story. It's not gone posterolateral. It's gone medial, not PMRI. No, this is not the one I'm thinking of. There we go. Sorry, my apologies. I get too excited sometimes. This one's gone pure medial. And this is not any of the previous mechanisms that we saw. This is not Ronda Rousey. This is not a Wrestler Boy. This is not a weightlifter person. This person's had a pure varus force across the elbow. Okay. And they've got a big injury to the lateral structures of the elbow, the lateral ulnar collateral ligament, common extensor origin, lateral collateral ligament proper. I don't need the patient story. I don't need the examination to tell me that this elbow is unstable. There's their first images in their back slab, and you can see that it's dislocated. And you may think to yourself, well, maybe they never reduced it. There's the images in day one in theater, and you can see that massive drop sign of that elbow. There's no way that this elbow is safe to move. They didn't even save the AP when they screened it. They put it into a back slab, and we know that you get static incongruity, and there's the third time we've seen it dislocated. And that's the problem with these elbow injuries. When I screen the patient, I'll take you through my screening right at the very end. I pronate the arm to lock the radial head onto the capitellum and place a valgus stress. And we see that there's a little bit of opening of that medial compartment. And so they've ruptured AMCL, in my opinion, but probably not common flex origin. But when you put the varus stress across this elbow, you see the magnitude of that lateral injury. And when you get these massive lateral injuries, it's very seldom that they're stable. Once you've repaired the lateral collateral ligament, once you've repaired the structures, you check that the elbow is stable and congruent within the last 30 degrees, and then get it moving. And so sometimes the x-rays will tell the story. Here we see this 80-year-old. The humeral head, the distal humerus is sitting just underneath the subcutaneous border of the skin. The radial head is not in the same postcode as this distal humerus. There's been a massive injury. Now, whether this went medial to lateral or lateral to medial doesn't matter, but they've damaged everything from lateral side all the way across to medial side and anterior capsule, and there's no way this elbow is safe. We see on the static imaging already that slight widening on the lateral side. Unfortunately, she doesn't get followed up, and she ends up with unstable elbow at 4 months. And so those elbows, for me, which I'm not sure, is it safe to move? Is it not safe to move? Those are the ones that I take to theater, and I call it an EUA without the A, an examination under anesthetic without the anesthetic. I bring the image intensifier parallel with the bed, reduce the elbow, flex the elbow 30 degrees to unlock the lecunon from the lecunon fossa, and then I place a varus stress. Don't know if you can see the images in your top left there. My image is blocking it. And so here we see, I'm just opening up the lateral collateral ligament just a little. So in that image on the top, that's normal. There we can see LUCL is ruptured, but not common extensor origin. It hasn't gone a long way. And now I put my valgus force across the elbow. And the problem here is I've got an elbow that's slightly flexed, externally rotating on the shoulder, and it makes it look like there's a valgus opening, but it's not. And that's what those x-rays would look like if you pronate the arm to lock the radius onto the capitellum. And if I have a pronated forearm, I can tell that I'm doing my valgus stress. I would say that this one's normal. That one, they've ruptured AMCL. That one, they've ruptured AMCL and common flex origin. And here they've done the full reverse HORI. They've gone AMCL, common flex origin, anterior capsule, LUCL, LCL, common extensor origin. And when you're disrupted the tissues like that, that elbow is not going to be safe to move. So how do I define an elbow that's safe to move? It's one that is stable and congruent on screening to within the last 30 degrees of extension. And so although I've screened them on varus and valgus to get an idea of the magnitude of my medial injury and the magnitude of my lateral injury, what I really want to know is this elbow stable and congruent to within the last 30 degrees of extension? And so here I bring this elbow gradually into extension. I've done the lateral side, I've repaired the ligaments and internally braced them. And we see how that elbow is perfectly stable as I come into extension. You can do the hanging arm sign at the end if you really want to prove to yourself that that elbow is stable and safe to move. And so there's a few, 2 or 3 a year, that ever need an EUA. And the reason I call it the EUA without the anesthetic is because if I do find that they're not safe to move, then we give them the general anesthetic and we repair or internally brace whatever ligament needs repairing to allow me to keep that elbow stable. And generally I start laterally and only go around the medial side if I have to. So here we see a dislocated elbow. And in the first post-reduction images, it's already dislocated. This is telling me this elbow is not safe to move. It can't even stay in when it's just in the back slab. And if I have a look at my imaging, I look at the CT scan, and I'm looking now at my bones. Small little piece of the radial head, and it's already dislocated inside my back slab. There's no way that this elbow is safe to move. And so I need to take it to theater. I need to fix or replace whatever bony structures need fixing or replacing, repairing or internal bracing their ligaments until it is safe to move. And so here we screen her. We see a big opening on the medial side. AMCL, PMCL, common flex origin is gone, anterior capsule. I screen into a varus force and I see LUCL, LCL proper, and common extensor origin is gone. But I don't really care whether it's gone medial or lateral. What I want to know is it safe and congruent in extension? And it's not. It jumps before I get to the last 30 degrees. And so I've got to do something about it. And so I take her to theater. I replaced the radial head on this occasion because I didn't think I could fix it. I've repaired the lateral collateral ligament structures, common extensor origin as a mass repair. I screen her again, and she still opens up, but I don't care that there's still some valgus laxity. What I want to know is, are you safe and congruent to move? And as I bring her into extension, she jumps. She's not quite dislocated, but she's not congruent. And so I can't stop here. And so what I need to do is now go around the medial side. And so I've repaired and internally braced the MCL. She still opens a little because no one can get the asymmetric point perfectly, but she's better than she was before. But most importantly, as I bring her into extension, she's perfectly congruent, and as such, she's safe to move. The movement part is BESS, elbow, stiffness. 3 words into Google. Thank you.
Thank you, Lee. Very interesting presentation. You gave us some point that we can go deep in the discussion. So it's my pleasure to introduce the next speaker, Professor Adam Watts. He works right in a hospital. He's a pioneer of elbow understanding. He developed among the many papers he published his classification of complex fracture dislocation based on the new theory of the 3 columns. Thank you for joining us, Adams. We're more than happy to listen about your presentation of a complex instability of the elbow. Thanks.
Thanks very much, Alessandra, and thanks very much to SECEC for the opportunity to speak to you this evening. So we're going to talk about elbow fracture dislocations, and these are my disclosures. I will be showing some plates from Medartis, and I do receive funding for education from Medartis. So this situation is unfortunately not infrequently seen. The surgeon has attempted to achieve stability in this complex elbow fracture dislocation, but they haven't listened to Sara's talk that we heard earlier, where she talked about the importance of the coronoid in providing that anterior wall or buttress to the greater sigmoid notch. And so we've really, in the Wrightington classification, tried to emphasize the importance of the coronoid process in not only restoring stability, but also in understanding the pathomechanics of elbow fracture dislocation patterns that we see, and thereby providing us with a solution to managing these complex osteoligamentous injuries. So the Wrightington classification divides elbow fracture dislocations into A, B, C, and D. A is an anteromedial facet fracture without a fracture of the radial head or anterolateral facet. So an isolated anteromedial facet fracture. The B type is a bifacet fracture, which can be with a radial head or fracture or without. The C type is a combined radial head and anterolateral facet fracture, or it could be an isolated multifragmentary or common usage radial head fracture, because the management algorithm for those two is the same. And then the D type are the distal or diaphyseal fractures, which are where the coronoid process is in continuity with the olecranon, and they can be with or without a radial head fracture, the D or the D plus. And for each of those injury patterns, we provide a management algorithm for treating these injuries. And we've published previously our experience in managing patients using these algorithms and reporting favorable outcomes in the vast majority of patients, even with very difficult fractures. In order to understand the Wrightington classification, we have to have some basic principles, and that is that the forearm can be divided into three columns. We have the lateral column, which is the radial head, the middle column, which is the anterolateral facet of the coronoid process, and those two lie lateral to the fulcrum of varus valgus stability. And then medial to that, we have the anteromedial facet of the coronoid process, which is the only column medial to that fulcrum. But because the elbow is a complex articulation, there are actually rotational elements to that, those instabilities. And so those ligamentous structures that Sara nicely talked about are important for controlling those rotational forces. And we'll come on to talk about that in a little bit more detail. One of the important principles to understand is that if I took away the lateral facet of the coronoid process, the elbow is completely stable because the radial head is still intact, the ligaments are still intact. Now, fortunately, that is very rarely seen, but sometimes we do fracture our radial head. The elbow is only partially unstable because we still have a column lateral to the fulcrum, but it's a narrow column. It's got a short moment arm. And if that injury is associated with a ligamentous injury, then that you will have that rotational instability because of the osteoligamentous injury pattern. If I, however, take away the lateral facet and the radial head, then the elbow is definitely unstable because there's nothing lateral to our fulcrum, and therefore we're going to collapse into valgus. So that's what we traditionally call a terrible triad injury. But because we now understand the biomechanics and the stability of the elbow, we know that to restore stability in this situation, we just need to restore the radial head. We don't have to fix the lateral facet of the coronoid, but we probably need to address the lateral ligamentous complex almost certainly. We might have to go medially and fix the structures on the medial side. That's probably only necessary if we've torn the tendons off the bone medially. But if we're going to go in medially and fix the tendons, then we might as well fix the ligament as well on the inside. But that's only if there's still marked valgus instability having addressed the lateral side. If I take out the medial column, the anteromedial facet of the coronoid process, then we've taken out the only column medial to our fulcrum. The elbow is going to be unstable. And look what happens on the lateral side. Those rotational stabilizers are torn, that lateral ligamentous complex, but also because it's a rotatory instability pattern, the posterior band of the medial collateral ligament. And we know how to address it. Fix the anteromedial facet, fix the lateral complex, and more often than not nowadays, we also fix the posterior band of the medial collateral ligament. So I want to look at each of these patterns in a little bit more detail and talk about the nuances of managing these injuries. So if you see an isolated coronoid fracture, even if it looks like a very insignificant injury, it is, until proven otherwise, an anteromedial facet fracture of Wrightington type A, and that's also what we could refer to as a posteromedial rotatory instability or posteromedial fracture dislocation. The important thing to recognize is that concave fracture on the medial side, which is caused by the medial trochlear ridge driving through the coronoid process, a bit like the wheels of a truck through snow. It's just driven through that anteromedial facet, taking out a piece of bone the same shape as the posterior trochlea. These injuries are sustained by falling backwards onto your hand. And you can see, as we've described in the three-column concept, exactly what happens. The lateral ligament comes off as a sleeve, and as we rotate round further, we tear the posterior band of the medial collateral ligament. These injuries may extend a bit more laterally, but even if they extend more laterally, we still have this concave appearance of the fracture on the CT scan. The important thing is to recognize the value of a 3D reconstruction of your CT scan. CT scan is mandatory, 3D reconstruction is very helpful. And also sometimes the injuries will involve the sublime tubercle, but that is more rare, only about 30%. Where you see that, you know that the anterior band of the medial ligament is also involved, and that needs to be addressed. You can probably appreciate on that CT scan the posterior band of the medial collateral ligament avulsed from the humerus. And in my experience, they always come off the humerus, and we need to address those if we need to do any surgery for this patient. And that's a really fundamental question. Does the patient need surgery or don't they? We do know that some patients with a PMRA pattern will get away with non-surgical treatment. And in my experience, it's those in whom there's a fracture, but the ligaments are intact. And so we use MRI scan to assess that. You can use ultrasound, you can use an EUA, as Lee talked about in his talk. If the ligaments are torn and you've torn and you've fractured the anteromedial facet, then I think it's likely they'll have persistent instability, and therefore we will need to address that by fixing the lateral ligament complex, fixing the coronoid process, and increasingly fixing the posterior band of the medial collateral ligament. It doesn't matter whether you use arthroscopic techniques or open techniques, it depends what your skill set is, but it's important to think about the trajectory of your screw. If you're using a screw to fix the coronoid process.
So hopefully you can see my slides there. So we're talking about the B type pattern of elbow fracture dislocation. We've borrowed from the ring classification, where you can divide them into apex anterior, apex posterior fracture dislocations. And the apex anterior, the radial head escapes from the anterior humerus. The apex posterior, the radial head is driven in to the humerus and is fragmented. So that's a B plus type. Apex anterior, recognize the important fragments. Fix and address the coronoid process, and if you need to, the sublime tubercle. And we used to teach that you needed to use independent lag screws through the coronoid process because most dorsal plates wouldn't address those coronoid fragments. We now have plates with cluster screws which will address the coronoid satisfactorily through the plate, but you need to know the hardware that you're dealing with. The B plus pattern is the apex posterior. It has a much worse prognosis, and it's the sort of fracture that you look at and you think, where on earth am I going to start with this? So McKee helped us with this and advising us that we can access the coronoid through the olecranon fracture, fix the coronoid, and then reduce the olecranon fracture to address that. And equally, you can address the radial head. Important to fix the coronoid first, so you know the height of the coronoid, height of the radial head, so you restore the correct length for that. Just be aware of this fracture pattern, which is a B plus injury, but where the base of the coronoid is attached to the coronoid process. So here you must fix the olecranon before fixing and reducing the coronoid process. And also be aware of this injury. So this is a B plus injury. It's a basal coronoid fracture with a radial head fracture, which traditionally we've thought of as one of those terrible triad types of injuries. But this isn't a terrible triad. This isn't a valgus external rotation injury. This is a direct posterior dislocation. The anterior ligaments are intact. It's the posterior ligaments that are torn. So that you must fix the coronoid, you address the radial head, but then fix the posterior ligamentous structures. So recognize that variant injury. This is the terrible triad injury, the valgus external rotation injury. Radial head's been driven into the humerus, anterolateral facet has been driven in, but the anteromedial facet is intact. Address the lateral column, address the lateral ligament complex, ignore the coronoid, and you only need to go medial if they're still unstable, but recognize these different patterns of injury. And lastly, the D or D plus injury pattern, which is your traditional Monteggia type of injury, which is the D type, or a D plus, which is where the coronoid is in continuity with the olecranon process. The ulnar fracture is distal to the coronoid, but apex posterior, the radial head is driven into the humerus and is fractured. And the important thing with those D types, you've got to restore the length of the ulna first before addressing the radial head. There are other classification systems, and the Mayo group have described this classification, in which you've got the transulnar basal coronoid, which fits with our B type injuries, the Monteggia variants, which fits with our D type of injuries, and then the transolecranon fracture dislocations, which we think of more of in the olecranon fracture classification, again described by the Mayo group. So hopefully that classification gives you a useful a useful structure to recognize the patterns of injury of elbow fracture dislocation and then plug in those injuries into the management algorithms to give you a good predictable outcome. Thank you very much indeed.
Thank you so much for your very interesting presentation. It's now my pleasure to introduce my colleague, physiotherapist Tom Verhoeven from Belgium. He's the founder of Motion Lab, a center specialized in sport rehabilitation and retraining. Tom has extensive experience in elite sports, having worked with the Belgium Olympic team and the Belgium Judo Federation for more than 2 decades, including 6 Olympic Games from Sydney to Tokyo. Tonight, in this joint webinar, he will speak about rehabilitation after traumatic elbow instability.
Good evening, everyone. A special thank to Roger and Jagwant for the invitation in the name of SECEC. Today I will talk about the rehabilitation of elbow instability in athletes. The main message of this presentation is that the elbow should not be seen as an isolated hinge joint. It's a complex joint that has to combine mobility, stability, and force transmission. In sport, the elbow often functions as a link between the body and the hand. Whether we are talking about throwing, racket sports, gymnastics, CrossFit, or contact sports, the elbow has to tolerate high forces, often at high speed and often under fatigue. So in rehabilitation, our goal is not only to make the elbow pain-free, we want to restore control, load capacity, and confidence, and eventually expose the athlete again to the specific demands of their sport. Although the elbow looks like a relevant small joint, biomechanically it's very demanding, as shown in the former presentation of Sara. When we look at elbow instability in sport, it is useful to think in terms of force direction. In overhead athletes and throwing athletes, valgus stress is often the key mechanism. This mainly loads the UCL and the flexor pronator mass. Examples are baseball, javelin, tennis serve, or other overhead movements. Posterolateral instability is a different pattern. It can occur after falls, in gymnastics, or in contact sports. Here, the lateral ligament complex and the extensor mechanism are important. After a dislocation or traumatic episode, the capsule and ligament complex may be involved more globally. In these athletes, the feeling of confidence and safe movement is often just as important as strength. Finally, we should also consider repetitive overload and fatigue. The elbow often becomes symptomatic when the kinetic chain fails. If the legs, trunk, scapula, or shoulder do not contribute well, the elbow has to compensate. That is why I would always screen pain, apprehension, range of motion, swelling, neurology, and the function of the scapula, trunk, and hip. The central rehabilitation principle is protect what heals, but move what becomes stiff. Progression should be criteria-based, not only time-based. Of course, time and after injury or surgery matters, but the athlete's response to load matters even more. I like to think in 5 broad phases: protect, range, control, load, and sport. In the protect phase, pain, swelling, and the feeling of instability should decrease. In the range phase, we restore a safe arc of motion without provoking symptoms. In the control phase, the scapula and forearm should be able to provide co-contraction around the elbow. In the load phase, strength and fatigue resistance become more symmetrical and sport relevant. And in the final sport phase, the athlete must perform sport tasks at speed and under fatigue. Important, these phases are not rigid boxes. They overlap. And especially after surgery, the physician or surgeon determines important restrictions such as brace use, allowed range of motion, loading limits, and return to sport timing. In the first phase, the aim is to calm the elbow down, protect the healing structures, and restore safe range of motion. We do not want to create a stiff elbow. Therefore, active movement within a safe arc is usually important. Depending on the direction of instability, we may use a brace or tape. We also continue to train the hand, wrist, shoulder, and scapula because the whole upper limb needs to stay active. Pain-free isometric co-contraction can be used early as long as it respects tissue irritability and medical restrictions. At the same time, there are movements we want to avoid. Examples are hanging traction, aggressive end-range valgus or varus stress, sudden supination extension in cases with posterolateral instability risk, and early plyometrics or throwing before the athlete meets criteria. A simple and useful rule is the 24-hour rule. Load is appropriate if pain, swelling, and the feeling of instability return to baseline within 24 hours. If not, we reduce volume, range of motion, or speed. In the second phase, we focus more on local stability. The elbow becomes more stable through timing and co-contraction, not only through maximal strength. On the medial side, we train the flexor pronator mass. This can include grip combined with pronation, eccentric wrist flexion, and exercises that challenge valgus control. On the lateral side, we build the extensor supinator contribution. This is important for rotary control and for closed chain support progressions, especially in athletes who load the arm in weight-bearing positions. Biceps and triceps are also important. They provide compression and braking capacity. For example, triceps control is essential when the athlete needs to resist fast extension or decelerate the arm. The progression is usually from isometric to isotonic to eccentric and finally to fast or reactive work. These are examples from controlled exercises for the elbow in the second phase. We slowly go from analytic exercises to the use of kinetic change. This slide is one of the key messages. The elbow is not the engine, it's a transferred station. The power in many sporting movements starts from the ground, passes through the legs and hips, then through the trunk, scapula and shoulder, and finally through the elbow, wrist and hand. If there is an energy leak somewhere in the chain, the elbow often pays the price. So we should screen more than the elbow. We look at lower limb strength and landing control, trunk rotation and thoracic mobility, scapular control, shoulder range of motion and cuff function, and grip, wrist and forearm endurance. A useful coaching cue is let the ground do the work. The elbow only passes a force through. In practice, when an athlete becomes fatigued, we often see compensation, first in the trunk or scapula, and only later pain or stress at the elbow. At the end, we are integrating the kinetic chain and looking for the valgus and varus stress. Exercise progression should move from isolated control to integrated sport function. We may start with isolation, isometrics, range of motion, and grip work. Then we move to closed chain positions such as table support, quadruped, or wall press. After that, we add a line of force using bands or cables, combined with trunk and scapular movement. The next step is reactive work, catching, throwing, perturbations, and deceleration. Finally, we move to sport-specific exposure, where angle, speed, contact, and fatigue are included. The key is dosage. We usually progress volume first, then range of motion, then speed, and only later external chaos or in unpredictable situations. The final phase of rehabilitation must be sport-specific, because the same elbow faces very different demands in different sports. For overhead or throwing athletes, we need a structured throwing or serving progression. This may include interval throwing, long toss, mount progression, or serve volume. The key loads are valgus stress and deceleration. For racket or striking athletes, the important factors are contact point, grip, rotation, and repetition volume. These athletes need to tolerate impact and eccentric control after contact. For gymnastics and CrossFit athletes, we must think about handstands, ring support, push-up depth, and other closed chain positions. Here, compression and rotary stability are very important. For contact sports, we have to prepare the athlete for pushing, pulling, falling, and unpredictable forces. In some cases, brace or tape use during contact situations may be relevant. The important point is that we should not test only one perfect repetition. We also need fatigue, decision-making, and match volume. Return to sport should not be based only on being pain-free. The athlete should have no instability, feeling, or swelling after training. Range of motion should be full or at least sufficient for the sport. Strength and endurance should meet the demands of the sport, and side-to-side comparison can be useful when appropriate. Provocation tests and apprehension should be negative or clinically acceptable. And most importantly, sport-specific tasks should be repeatable with good quality. I like to use a progressive exposure model. First technique, then maximal volume, then speed, then chaos or opponent pressure, and finally competition. A traffic light system can help. Green means the athlete can progress. Orange means repeat the same level. Red means we go back to the last stable level. To summarize, this is the practical algorithm. First, diagnosis and plan. What is the direction of instability? What are the restrictions? Is there a brace? Is there surgical input? Second, monitor the response. Pain, swelling, apprehension, and the 24-hour response guide are decisions. Third, restore range of motion and local control. We need a safe movement arc, co-contraction, and forearm contribution. Fourth, integrate the kinetic chain. The elbow has to work together with legs, trunk, scapula, and shoulder. Fifth, expose the athlete to sport. We move from volume to speed to chaos and eventually to competition. At every phase, we ask the same question. Can the elbow transmit sporting force stably? To conclude, elbow instability rehabilitation in athletes is more than local strengthening. The elbow is complex. It needs mobility, stability, and force transmission. Rehabilitation should protect healing tissue, but also avoid stiffness. It should restore local control, but always within the context of the whole kinetic chain. The end phase must be specific to the athlete's sport, position, level, and season, and return to sport should be based on criteria, not on time or pain alone. Thank you for your attention.
I'm happy to introduce our next speaker, which is Pieter. He's a world-known elbow surgeon. He was also awarded the SECEC Prize for Elbow Research due to their work in distal biceps pathology, and he's based mainly in Belgium, and we are very happy to introduce this part of the session that will be on chronic elbow instability and how to deal with these problems when they become more complicated after this first attempt of instability. So, Pieter.
So thanks to SECEC and EUSSER for the kind invitation. My talk is going to be on chronic atraumatic instability. And we're going to discuss some different topics. We're going to discuss general hyperlaxity. We're going to run over lateral instability and medial instability. And if you think about generalized hyperlaxity, of course, we all think about the Ehlers-Danlos syndrome. And it's very important if you encounter a spontaneous dislocation, which is, of course, very rare, to evaluate the other joints and to possibly calculate the Bateman score. Because as you see in this case report by Roda, there's a spontaneous repetitive dislocation. And then we might need some other stabilizing factors such as allograft or potential synthetic grafts to offer stabilizing force for the joint. So it's very important in these rare cases to evaluate the other joints and see if there might be a case of generalized hyperlaxity. If we look at the lateral side, we're going to discuss, of course, different aspects, and this is a quick run over the ligaments that Sara already adequately presented. So we have the ligament structures and we have the muscular structures. They co-work to offer stabilization factors. And the different topics that we're going to discuss are first the smile lesion, which is symptomatic minor instability of the lateral elbow. We're going to discuss iatrogenic instability and then instability in coexistence with lateral epicondylosis. So symptomatic minor instability of the lateral elbow, it's the topic that, of course, Paolo Arrigoni, who speaks after me, has made famous, and it's the concept of an injury, either a pathology or degenerative microtrauma to the radial band of the collateral ligament. And what you have to understand is that we push a lot of various force over the elbow with daily activities, such as, for instance, the pouring of a can. And these repetitive various forces may lead to an elongation or injury of the radial band of the collateral ligament. And cadaveric studies have shown that the radial band of the collateral ligament is really important to stabilize the lateral elbow. And if we have an increased varus force to an elongation, there will be a hyperpressure or a compression of the radial head against the proximal ulna, which leads to degenerative changes, of course, around the elbow. So there's a patholaxity or micro instability, which is in the end symptomatic due to the intra-articular changes. It's different from PLRI, and that PLRI, if we can have the videos, in that PLRI is a vertical instability, while smile lesion is a horizontal instability. So in PLRI, there's a movement of the complete forearm in comparison to the humerus, while in the smile lesions is actually a hypermobility of the radial head comparative to the ulna. We can see that in arthroscopic images as a loose color sign, because of course the annular ligament is integrated with the radial band, and you get a sagging of the annular ligament, and we get an increased motion of the radial head. If conservative treatment is unsuccessful, and conservative treatment is of course a stabilizing exercise program as we've seen before, then we might consider to do application of the radial band of the collateral ligament, and this has been described by Paolo Arrigoni as well, and you can find very nice papers on that. The following topic is iatrogenic instability that can be either post-surgery, as you can see in this case. This was a lady who was operated 3 times for lateral epicondylosis, and as you can see, there's severe damage to both the ligamentous structures and the tendinous structures. A second possible cause is injection therapy. We just included a cohort of 500 MRI scans in which we saw instability in approximately 58%. And of those, 44 had injection therapy. And we see a clear correlation between the amount of injections they had and the severity of the tendon injury and the severity of the LCL injuries. In chronic PLRI, of course, there are different clinical tests. You can perform the push-up, the chair test. You can evaluate the elbow with the posterolateral rotatory test. And I agree with Lee that in acute cases, that's very hard. But in chronic cases, you can evaluate the motion of the radial head compared to the humerus or the capitellum. The most known test is, of course, the pivot shift test, which is really hard in awake patients, but in patients that are asleep, you can evaluate the motion of the radial head by performing axial compression, valgus, and supination. In chronic PLRI, we can perform MRI scans to evaluate the structures. And we can also perform an arthroscopic test in which we increase the instability by the amount we can put an obturator from the lateral to the medial side. Treatment can be conservative, although there's very little literature on that. Of course, it all depends on the age and the requirement of the patient. Surgery will be discussed by Professor Van Liet later on. In epicondylosis, it's more recently known that can be a coexistence of instability of the lateral complex. And we see in different studies there's up to 23% of instability in coexistence with lateral epicondylosis. The classical patient is, of course, the 45-year-old with overuse pain, decreased strength, and radiating pain to the forearm. But what's really difficult is to identify those patients that also have instability, because the normal diagnosis is clinical with history taking, mobility, and stability evaluation by the posterior drawer test. And furthermore, we're going to test the extension of the wrist, both in flexion of the elbow and afterwards in extension of the elbow. And when the elbow is in extension, there's more tension on the muscles and it will be more painful. To evaluate instability, we propose a resisted anterior drawer test in which we're going to stabilize the radial head by pushing it anteriorly and then do the resistant wrist extension again. As I said before, we evaluated 500 patients, did clinical testing and MRI, and compared the clinical testing with the signs of instability on MRI. And we saw is, of course, the normal demographics of a lateral epicondylosis with patients around 50 years old. The duration of the symptoms is quite long. It's around 20 months, but that's dependent on the patient demographics that we have in our practice. Most of them had physiotherapy and brace therapy. And like I said, almost 44% had at least one cortisone injection prior to our visit. About 80% had signs of tendon tears, so it's quite a common occurrence. There was about 50% of them with signs of LCL lesions, About a third had posterior sagging of the radial head, and about the third had an opening of either the radial humeral joint or the ulnohumeral joint. As I said before, please do not inject cortisone, as we see that there's a clear correlation between the tendon tears and LCL tears and cortisone injections. If we look at the testing in unstable patients, we see a more painful wrist extension with the elbow in extension. However, we see a greater drop of the VES scores when we perform the stabilizing of the radial head. And this you can see in this imaging. And if we look at the sensitivity and specificity of this test, we see that there's a higher sensitivity than the posterior drawer test. And although there's a lower specificity, we still deem that it's really a valuable tool in the diagnosis of instability. This is a sensitivity if we say that there has to be at least 3 points of drop with the stabilizing of the radial head. If we put it to 1, the sensitivity and specificity even increase. We, of course, look to the future, and we see that there might be a possibility in the rehab. If we do taping with these patients, we look at the strength testing immediately after taping, and we see an increase about 36% immediately after taping. So this will not, of course, heal them, but might help them to perform their exercises that are needing for their rehab. Finally, there might be options for surgical treatment, and we still don't know if we have to treat the LCL alone or do a combination with the epicondylosis treatment. Finally, we're going to look at the medial side. Again, the ligaments and the muscles are important, of course, and we're mainly going to look at the valgus extension overload syndrome. What occurs is that in patients, and there's mainly baseballers or in European countries, overhead sporters, there's quite a significant valgus load every time they throw, for instance, and this gives medial strain on the medial collateral ligament. Just to know, in the lab, the ligament can take about 35 Newton meters, and every time they throw, they put about 64 Newton meters on the ligament. So they have a chance every time they throw to rupture the ligament. Why don't they do it? Because, of course, there's muscular compensation that compensate for the strain on the ligament. However, if that fails, then we get a stretch of the MCL, we get a radiocapitular compression and a posterior medial osteophyte occurrence because of the bumping of the olecranon against the humerus. On CT scans, you can identify the posterior medial osteophytes very clearly, and on MRI scans, you can evaluate the potential lesion of the MCL. Symptoms, patient complain of loss of strength and precision, clicking, grating, posterior medial pain, and if you do a pre-season testing, you can quite often see that there's an extension length due to the posterior medial osteophyte. We can, of course, do the classical testing of the MCL that we've seen before, as palpation of the MCL, milking tests, and in posterior medial impingement evaluation. We can do that by palpating the posterior medial side. Of course, this can be confounded by the ulnar nerve, but we can mainly do a posterior medial impingement test in which we can gonna put the arm in pronation and put a valgus force over the arm. Treatment will be mainly prevention and conservative treatment with adaptation of the technique and strengthening. And we can, of course, improve the kinetic chain as we've seen by Tom. Surgically, we're gonna do it only when there's failure of conservative treatment, however it takes. However, we're sometimes gonna have to take into account the time pressure of the season and the time out of play. There's 2 potential surgeries that can be performed. If the instability of the muscles is compensable, we can remove the osteophyte in an arthroscopic fashion, and we can evaluate in the same time other potential lesions. However, if the muscles are not compensable, so the patient cannot compensate for the instability, and MCL reconstruction might be indicated, and this again will be discussed by Professor Riet. Thank you so much.
Thank you, Pieter, for diving in this very complex topic about elbow instability. So it's my pleasure to introduce Paolo Arrigoni. Paolo Arrigoni is not just a friend of mine, but also a very creative and brilliant surgeon. He works in the Gaetano Pini Orthopedic Institute and is the one who discovered new theories about the elbow instability, as we saw, like a smile. Welcome, Paolo.
Special thanks to Pieter also that cited my works. And it's a pleasure and an honor to be here. And thanks to all the other speakers. And we're going to talk about chronic post-traumatic elbow instability. So to make things very, very easy, when we talk about chronic instability, we have to face 2 completely different animals. One thing is recurrent instability. One thing is persistent instability or dislocation. Recurrent, it goes back and forth. So the elbow goes back and forth and tend to re-enter. Chronic persistent, the elbow is out, completely out. It's quite rare to see it routinely in our countries. In European countries, it's much more common in African countries and other countries. But those are 2 completely different animals because, I mean, in the very first scenario, the ligaments are continuously stretched, so they are incompetent. The quality is lost. In the second case, somehow ligaments are there, are elongated, but they don't continue to stretch. And maybe there is some ways to save that material, just to let you know. So there are several systems to classify this. Of course, the Mayo Clinic, they've been working a lot about this, about angles, about recurrence, degrees, timing, joints. Also, Alessandro Marinelli and the Italian Society of Shoulder and Elbow has been working a lot about trying to understand mechanical patterns and type of injuries, and if it's just soft tissue or it's soft tissue and bone. Of course, if it's chronic persistent, there have been very nice works from, in particular, I remember 2 webinars I've personally done with colleagues that work in Africa and in Iran about concepts that are basically releasing everything and X-fixing and trying to stabilize. And because of what I was saying before, because the ligaments are not overstretched, you may restabilize that elbow without reconstructing that elbow. There's a completely different scenario with respect to a recurrent instability. I want to point for a few minutes the attention on something that is in between, that is delayed presentations or situations where the trauma was not that evident. And unfortunately, and I think this webinar is perfect for describing this, we have this problem of instabilities where in the acute setting in particular, the term simple is used to indicate that there are no fractures. And I think it's completely wrong to talk about simple instability when there are no fractures, because they are not simple at all. And the term simple is really is very much misleading in these situations. Or again, to talk about marginal coronoid fracture, minimal coronoid fracture. Because every time we have a subluxation, the ligament is stretched, is elongated, and we have to say something about the quality of the ligament. Another point is about the cast effect. Cast effect is terrible sometimes, and in particular when the elbow is immobilized in full supination, because in this way, the elbow tends to slip out, and those ligaments are clearly stretched. Those are very dangerous scenarios we have to look carefully at. So delayed presentation, situations that were not clearly chronic, talking about a few months, but I mean, we're talking about a few weeks. And those are scenarios very difficult to understand, to diagnose, to catch. Now, of course, a lot of science. I'm not going to stop in this slide because my colleagues have been speaking a lot about arthroscopic science. But I want to just point out at one thing about understanding and considering the coronoid in acute setting, but also in chronic setting, not as a fracture or a non-union as a piece of bone itself, but as a bone loss. We have to think at the coronoid that is missing. And this is a very important point. We know that the coronoid is a bone stock. This is a very nice work that has been done by the group of Joy DeFundis about trying to understand and describe the height of the coronoid in a relative way, not in an absolute way. And we have been doing more or less the same thing with this concept of the DAM model and the clinical coronoid angle, basically trying to understand what was the real angle of coronoid, the prominence of coronoid that was in front of the coronoid in a semi-dislocated elbow, in a semi-extended elbow, because that's the real contribute of the coronoid to avoid a dislocation. And we found a significant difference in between people who had underwent a dislocation versus non-dislocated, so control groups. So looking at this problem, the amount of residual coronoid is critical, and I really want to push everyone that is listening to this webinar to consider coronoid in a relative way, not in an absolute way. So I bring you directly to this case so we can discuss maybe later. It's a male, 73 years old, fall in June 25, 3 episodes of instability, and range of motion 30 to 130 with apprehension and pain. This is the scenario with the clear non-union of a fragment of coronoid, and this is the CT scan, and we can see that coronoid, and we can talk, and maybe there is an open, we can have an open discussion about if that coronoid is fixable, non-fixable, we need to graft. Our solution was to address first the coronoid arthroscopically. Another point that you can see here in this CT scan, we can talk later, is about what happens in the posterolateral corner. We have been working a lot on lesion of just the bone or with or the soft tissues, and this is something that can guide our decision making. So basically, we went in arthroscopically with the idea. With the plan was the idea of refreshing the fracture, and if we were able to fix a fragment, or to graft in case this was not possible. And we understood almost immediately that the fragment was fixable. And we used this technique that we described some years ago, basically passing through an accessory anteromedial portal, inserting a K-wire that goes back posterolaterally, then reusing the fragment and re-advancing the K-wire into the coronoid fragment. Of course, you can do also in another way. There's posterior to anterior, where you know that there are relative distance coming down from the olecranon and going distal. There is an index that we have described here, trying to stay in between the apex and the base to shoot a K-wire or later on a screw. So at the end, it came out that we positioned several screws that pass posterior to anterior, stabilizing the fragment. So we positioned 3 screws, 2 posterior to anterior and 1 oblique. And then, because we were there arthroscopically, you can address everything around that elbow. So we went posterolaterally, and of course, because it was a chronic case, the quality was very poor of the ligament, and we decided to go for plication, inserting a suture anchor, a no suture anchor in the posterolateral compartment, like you can see here, and to progress with application of the LCL with the technique you may have already seen several times. So at the end, we did an anterior non-union management, an arthroscopic posterolateral management. Of course, you can do that also in an open fashion, while I do think that the coronoid, at least starting and addressing arthroscopically, it's a great advantage. And at the end, we went in the posterolateral, in the olecranon fossa, there was a loose body, and also the beauty of the possibility of addressing everything is that you can see all the compartments, and that's a very important advantage. This is the final X-ray that we have done. Of course, I'm not going to talk about this, but Roger has been describing this wonderful technique. I really think it's a great, really game changer on plicating the posterolateral compartment, and he showed up very good results in chronic settings, so this is a very interesting technique. Personally, we have cases in which we have managed people with several dislocations, recurrent dislocation, or several dislocations. So we're talking about 14 elbows in which we did the fully arthroscopic technique with 14 LUCL plication, 7 radial band plication, and 4 annular ligament plication. So a combination of the two. So it's basically a plication of all the bands of the ligaments, arriving to a very satisfying scenario with basically more than 2 years follow-up and good results with no redislocation. Of course, you can also go in situations in which the quality of the material is very poor to classic open fascial reconstruction. This is what has been described as a jaw procedure. Basically, it's a classic. There are several ways to do this: docking technique, tunneling technique. You can use all suture anchors, buttons, tunnels, but at the very end, the very final idea is to reconstruct the bands of the LUCL through a graft. The problem comes when it's stiff and unstable at the same time, so the anatomy is completely altered, and we have at this point 2 problems at the same time. The elbow is stiff, with a lot of material, extra bone, anatomy altered, you have problem with the ulnar nerve, and at the same time, if you remove everything, you are destabilizing the elbow, and later on you have to restabilize the elbow. But remember, the ulnar nerve at the posterolateral relationship is like a kid in the bed and is moving, it has to glide. It's very difficult to manage. So in those situations, my preference is to transpose the nerve. So at least we have separated a complex problem, ulnar nerve plus stiffness plus instability, in a situation where the nerve goes by itself and I can manage the rest of the joint. Of course, if we do extended releases, I'm ready to stage, and we're ready to stage for eventual secondary release, because of course at the very end we prefer a stable and maybe a residually stiff elbow than a completely destabilized and not stable elbow. So this is a very important thing. Just to make a point, I mean, you can also use a technique that is called the box loop technique, or the circumferential graft, where we do 2 tunnels, one in the ulna and one in the humerus, and we pass the graft circumferentially. This is a very nice technique that Roger every time says has been described the very first time by Greg Bain. Maybe Roger can change this, but of course this is a very important technique. I honestly don't like too much because sometimes I do think it's difficult for me to control how much tension I give. So normally I prefer to do 2 separate reconstructions separately on the lateral side and the medial side, but this is one point. Thank you so much for the time and your attention. Later on, probably we're going to discuss about this.
Thank you, Paolo.
You probably saw my daughter also passing on my back.
You made a great presentation, touching many points that we can discuss later. So it's my huge pleasure to introduce Professor Riet. He's a pioneer of the elbow understanding, and he works in the University of Antwerp. He's also the president of SECEC. So he's going to talk about open and arthroscopic treatment of chronic elbow instability.
Hi everyone, my name is Roger van Riet and I'll be speaking about chronic instability. I have some disclosures. I'm president of SECEC, for example. So when we're talking about instability, we've already heard this before. We're talking about a spectrum from minor to severe, etc. We're talking about a variety of patients, and patients factors definitely play a role. We're talking about a variety of treatment as well, and bear in mind that many of these patients already had some type of previous treatment that needs to be considered. This is an old slide by Sean Driscoll, and we see different grades of PLRI, 0 reduced to number 3 dislocated. We're talking about open versus arthroscopic treatment of lateral instability, grade 0 and 1, so slight dislocation or slight subluxation. No doubt in my mind, arthroscopy is indicated. If the elbow becomes perched, that means that the coronoid sort of perches itself onto the trochlea. You can discuss whether arthroscopy is still indicated or open, and we'll discuss both. This is how I do my arthroscopic imbrications. We get a big needle on the LCL origin. The needle is loaded with BDS2. This is the view from the radiocapitellar joint from the back. So we're now in the posterolateral portal. The needle is advanced into the joint. The suture is shuttled. We then go into the soft spot portal and grab that part of the needle of the suture. There you go. Most difficult part is already done. Then second one is on the subcutaneous border of the ulna, and we basically stay on the bone and pass the insertion of the LCL complex, which, as you know, is at the base of the annular ligament, base of the supinator crest. So that part of the suture gets shuttled in there as well. Retrieve it from the soft spot again, and then we tie both. It doesn't matter if you tie the proximal to the distal or the other way around. Tie both of them, pull on the one with the knot, and in this way you will end up with one strand of PDS intra-articularly, running from insertion to origin. When we started doing this, we figured that one strand of PDS probably not strong enough, so we double it, basically make a knot again, get a second strand, a second suture of PDS, put it through halfway, then pull. Again, doesn't matter if you do this proximal or distal, and there you go. You have a double suture intra-articularly going from origin to insertion. Little mosquito and really subcutaneous, so try to get as much soft tissue in the eventual loop as you can. So take them subcutaneous, and now we test the stability. So these now double suture between origin and insertion, but it's actually a loop with anchor-neas, with posterior capsule, lateral capsule, and LCL complex there. And then we test the stabilizing effect. So by just pulling on the arm, axial traction together with supination, you see how it subluxes. And now when we tighten the suture, you see how it reduces. We then tie both knots separately. Post-operatively, they get a removable splint for 2 weeks. We tell them to remove it from day one for a minimum of 5 times 15 minutes. However, they can remove it more often if they want. That's the beauty about the removable splint. The bandage stays closed for 2 weeks, after which we remove the bandage and then see what we need, whether we need actually to protect the patient a little bit more with a brace, or whether we can let them go and maybe start with physio. In our 10-year follow-up published by Rafael Koolpraat, pre-op we started with 47 Mayo performance score, and we went to 93, which was still there at 10-year follow-up. Quick dash similar, 53 to 8, and this girl was 12 months post-op. Initially she was okay with me filming this. 12 months post-op, you can still see the suture in her elbow. It's actually quite visible, and in 24 months post-op, the PDS has completely resolved and the elbow looks as normal, and for her feels as normal as well. If it's not possible, or if I feel that the elbow needs a little bit more biology, then we do a form of reconstruction. This is Koch's interval. As you can see, we get a little needle and we mark both sides of the needle on the bone. And these markings are actually, they start at the supinated crest. And at the tip of the supinated crest, when you put your finger on the supinated crest and follow it proximally, you get this little nubbin just at the base of the radial head or the base of the annular ligament. And from there, we place our needle, and as you can see, I do this in a longitudinal fashion. So many books it'll say, well, do it in a triangular fashion and tie them together. I feel the longitudinal fashion works better for me, and this actually came from the imbrication, because of course we do the same subcutaneous border. We cross the insertion, and when we cross the insertion, we start reconstructing. I use an allograft, but you can use whatever graft you want, of course, and you feel comfortable with. Then a guide pin in the lateral condyle, overdrill with 6 millimeters, then overdrill with 4.5 millimeters, and we use this ender button with the loop attached, and the loop can actually be tightened. Second cortex, make sure it is there. In the beginning, I used to use either fluoroscopy or maybe open the suture, open the incision a little bit more to make sure that the button was in the right spot. It should not be in the olecranon fossa, and it should not be too close to lateral condyle, because the bone is actually surprisingly soft there. So you can pull this out. Then we tie it as hard as we can. You see the elbow's in 90 degrees. Now it's in 70 degrees. Everyone always asks me what kind of degrees to use. I don't really care that much. I just leave the elbow there, whether it's in 90 or 70. It doesn't seem to change my the tension on my graft. The forearm is in neutral. Of course, if you want, you can add pronation to this and then maybe tighten it a little bit more. But the technique that we use is so tight that I don't feel that's of any benefit. We then suture the two limbs. We pull the two limbs back distally and then suture it together. I use the actual LCL for this as well, the actual capsule as well. And then at the end of the procedure, we just cut the whatever's left of the graft and close the Koch's interval over it. You can do this with a smaller incision if you want. You can make 2 incisions as well. That's been described. One for the distal tunnel and one for the proximal tunnel. There's nothing wrong with things like that. But I prefer to really see it. Post-op, same as LCL imbrication, no difference. Then valgus extension overload syndrome. As you know, valgus extension overload syndrome starts with valgus load. You get a medial strain. Because the medial strain, you might get an MCL failure. But luckily that doesn't happen because you have your muscular compensation, and with this muscular compensation, when that fails, you get an MCL stretch. MCL stretch causes radiocapitellar compression and ends up with osteophytes on the posteromedial side of the olecranon, together with radiocapitellar arthritis. The initially, of course, conservative treatment. If that doesn't work, you can do an arthroscopy for diagnosis. You can do an arthroscopy to remove osteophytes. In this case, this was a cricket player. He needed some laxity, so he didn't want me to stabilize his elbow. We removed a little fragment on the posteromedial side, and basically he'd be okay for the next couple of years. Open Tommy John surgery. This is Dr. Job and Tommy John. Tommy John is the player, of course, and Dr. Job was a pioneer in this career-ending. We don't have a lot of baseball players in Belgium, but this player insisted that we use the original Tommy John technique. We changed it a little bit, of course, do an flexor tendon split, sorry. The ulnar nerve is not inside, but I know exactly where it is. We palpate the ulnar nerve before we start doing this. And we just incise and then blunt dissection to medial collateral ligament. As you can see, again, the medial collateral ligament is intact, but insufficient. Then drill tunnel in the sublime tubercle, just distal to it, and then a small tunnel in the medial epicondyle at the insertion site. 2 exit holes. This is for the suture later on. You'll see this. And again, this is very important that you know where the ulnar nerve is at this point. If you're not sure, if you don't feel confident, there's no problem with finding the ulnar nerve, maybe releasing it a little bit to make sure that you do not injure it. This is important that we use a docking technique in this case, and it's important that the graft is not too long or too short, because when you pull it in the tunnel, you'll see that if it's too short, it will not go into the tunnel. If it's too long, it'll be too loose. So pull it in, suture the limbs together, and basically you've done the almost original Tommy John technique. Just suture them together, and that's it. We've been doing something different with our MCL reconstructions. The baseballer wanted something that's tried and tested, and this is a tennis player, top 100 in the world. And you see how, again, the MCL is intact but insufficient. He's been training a lot, he's done all the conservative treatment, but unfortunately not enough, and he wasn't able to play anymore. So we put an anchor in the distal end of the MCL in the sublime tubercle of the ulna, and we put an anchor in the proximal end, in just distal to the medial epicondyle. I use all suture anchors. Just my preference. I'm not sure if this is better or worse, but I like the fact that this is a very small drill hole, 1.4 millimeters. We're not disturbing the medial side too much. And again, these are patients where the MCL is not gone. It's not that like they have bad tissue, they have good tissue, but just a little bit too lax. Using an extensor iliacus longus allograft. Again, my preference, probably not better than any other graft. So this is important. This is not only sutured to itself, but definitely also sutured to the MCL that's underneath. So we leave the MCL intact and we tighten it a little bit with our suture anchors, and then we just strengthen it with our graft. I tie one limb of the proximal anchor to the distal anchor, and this way you get kind of like an internal brace, although we don't use internal brace as such. Post-op, again, a removable splint. More or less the same all the time, and this player was back to tennis without problems. So, in conclusion, chronic instability can be treated successfully with arthroscopic and open technique. Indication is key. Thank you very much. Please make sure that you come to Barcelona September 2 to 4 for our annual SECEC meeting. It's promising to be one of the best ones so far, although we say this every year, of course, but it has been better every year. So there's still time to register. Barcelona, September 2 to 4.
Thank you very much, Roger, for your very good presentation. Now it's my pleasure to welcome my colleague, physiotherapist from EUSSER, Dr. Marcus Bateman. He is a consultant upper limb PhD physiotherapist at the University Hospitals of Derby and Burton, and a highly respected researcher in shoulder and elbow rehabilitation. As an active member of EUSSER and author of numerous international publications and guidelines, he is currently leading several major research projects focused on upper limb rehabilitation and elbow pathology. Tonight, he will speak about rehabilitation after chronic elbow instability.
Good evening. My name is Marcus Bateman. I'm a consultant physiotherapist from Derby in the UK. I specialise in shoulder and elbow rehab. In this lecture, I'm going to talk to you about the rehab of patients with chronic elbow instability. My research is funded by the National Institute of Health and Care Research in the UK, but I have no direct conflicts of interest to declare. As many patients with chronic elbow instability end up having surgical reconstruction, I'm going to talk to you initially about the early mobilisation after surgery, and in particular focusing on bicep sparing exercises, before moving on to exercises that are common for patients treated operatively and non-operatively. So we'll start with some simple stability exercises and moving on to general upper limb conditioning, proprioception training, and then some sport-specific rehab at the end stage of the patient journey. I should say at this stage that much of this talk is based upon 25 years of clinical experience as opposed to research data. Unfortunately, for this patient population with chronic elbow instability, there's very limited research evidence to guide our rehab. So in this talk, I will refer to some published evidence, but these papers include patients from a slightly different population to the chronic elbow instability patients that we're specifically focusing on in this talk. We all know that patients after elbow trauma or elbow surgery can develop elbow stiffness very quickly. So after surgery, it's important that patients mobilize early. It's therefore important that there are good lines of communication between the surgical team and the physiotherapy team, so that post-operative physiotherapy can be booked in ideally before the procedure to avoid any issues with waiting lists, and also for the surgeons to communicate exactly what was done during surgery, so that the physios now know how hard to push the patient rehab without compromising any surgical repair. The paper on your screen refers to a study that looked at patients after acute elbow dislocation, and they were randomized to either 3 weeks in plaster or early active mobilization. After a year follow-up, there was no difference, but patients who mobilized early achieved faster recovery of their range of movement and faster recovery of work and function, leading to lower socio-economic costs and therefore better cost effectiveness without any additional complications. I would always start with bicep sparing exercises. So these are active range of movement exercises simply for mobility of the elbow joint. The exercises are done using gravity instead of bicep contraction to try and minimize the sort of protective spasm that patients sometimes get in their bicep that can overall restrict recovery of extension patterns. So the patient actively uses their tricep to extend, then uses gravity to allow flexion, and if necessary, if there's some stiffness, they can add some gentle overpressure. It's always helpful if post-surgical dressings are kept to a minimum, as bulky dressings can get in the way of the active movement. The benefit of doing active movement over passive movement or continuous passive motion, CPM, is that the patient is in control and should be instructed not to push beyond bounds of pain, therefore minimizing the risk of post-surgical complication. The Sheffield Elbow Unit have previously demonstrated that bicep sparing exercises result in greater restoration of flexion extension arc compared to conventional exercises. This was in a patient population who had radial head fractures, but from experience this applies to any group of patients who've had elbow surgery or trauma. Compression garments such as tubular bandages or compression sleeves may have a useful purpose initially after surgery to control any post-operative swelling, but beyond that can improve elbow proprioception, which is an important factor when rehabilitating an unstable joint. These can therefore be considered in patients treated non-operatively as part of their rehab. As with any joint, stability is determined by the passive structures like the articular surfaces and the ligamentous constraints, but also the dynamic stability from the muscles that surround the joint. It's therefore very important for patients initially after surgery to restore their muscle function as quickly as possible. The bicep sparing exercises can easily be progressed with light weights, to facilitate co-contraction of the forearm muscles and the tricep. Dynamic stability of the elbow joint has multiple factors. So there is co-contraction of the elbow flexors and the tricep. This can be trained by doing carrying exercises, either with a flexed or extended elbow. An extended elbow puts tension through the passive ligamentous constraints, whereas a flexed elbow releases the ligamentous constraints and relies more so on the dynamic stabilizers alone. So load can be light to begin with and progressed as tolerated by patients. This can easily be done at home by patients using shopping bags in each hand and increasing the amount of weight in the bags and progressing the amount of carry time by the length of distance that they're carrying the object for. The ulnar side of the elbow joint gains additional dynamic stability from the long finger flexors and long wrist flexors. So in the early stages post-operatively, it's very important to give exercises involving gripping and flexion curls of the wrist. These can be done in the very early stages, even when the elbow is very painful, as the hand and wrist movements tend not to aggravate the patient's post-surgical symptoms. Then later on, in post-surgical cases or in the chronic conservatively managed patient, we can add in more dynamic controlled simulation exercises that involve those muscle groups. For example, a forearm tennis or paddle type stroke using a TheraBand or weighted cable. Similarly, dynamic stability is provided on the radial side of the elbow joint by the long finger extensors and long wrist extensors, as well as anconeus. So again, in the early stages post-operatively, wrist extension exercises can be incorporated very early and then progressed into more dynamic situations such as backhand tennis motions. So here are some examples of early wrist extension loading. On the left, there's a simple isometric extension exercise which can be done very early post-op, even with heavy dressings and significant pain. And then as the patient recovers, they can move more towards dynamic exercises. I like to do really slow exercises to begin with. Here we are seeing a 6-second arc from flexion to extension, and the elbow is in an extended position. The amount of elbow flexion can be increased as the patient becomes more comfortable, as well as increasing the speed, so getting the patients to do some really slow controlled exercises and then some much faster activities that are more functional. It's also important to do some general upper limb conditioning to strengthen around the shoulder girdle. That can be done as soon as tolerated using light weights and then progressing on to weight-bearing activities in due course. Once the patient's achieved a basic level of elbow and forearm strength, we can then start working into more challenging positions. So here in these videos, we're challenging the dynamic stability of the radial side of the joint using the extensor muscles on the left in a controlled fashion, and then on the right with the drop and catch, there's more of a plyometric component, which is a step up in difficulty. Obviously start with a small weight and progress the amount of load as tolerated by the patient. It's also important to work on proprioception, so this can be done by weight bearing through an uneven surface. So here on the left with minimal body weight using a ball on the wall, or it can be progressed with increasing body weight into kneeling or into a full push-up position, and then progressed further from a straight elbow to a flexed elbow. Once the patient's mastered this, then they can progress to more challenging activities such as a controlled fall, firstly on an incline, and then can be done in kneeling or a full push-up position on the floor. Lastly, we can move on to sport-specific rehab that is tailored to the patient's individual needs. Here we see a throwing action where the patient can start off slowly and gradually build up to the velocity on a weighted cable until they're up to their normal throwing speed. If you have any questions for me after the webinar, please don't hesitate to contact me through social media on X or Blue Sky. Thank you.
Start with the discussion. Solenn, do you have any question?
Yes, I have two questions to my colleague as a physiotherapist. So, Marcus, thank you very much for your very good presentation, showing the importance of active movements in the early stage of rehabilitation, especially with your very practical biceps sparing exercise. I have just one question. Do you think rehabilitation outcomes for those patients depend more on restoring stability or restoring confidence and movement control?
I think it's a bit of both, actually. I think without the sufficient stability, you aren't going to achieve a good result. Either the patients compensate and get extremely stiff because they don't have the confidence to move their elbow, or they remain unstable. But on the flip side, you need to try and instill confidence in them, get their trust. And it's really important that they engage with the rehab early, because if they delay and the elbow does get stiff, particularly after surgery, it's really hard to get that range of movement back once it has got stiff.
Yes, I totally agree. The other question is for Tom, and thank you so much for your very good presentation too, showing the importance of the kinetic chain during elbow rehabilitation. And how early do you integrate kinetic chain during rehabilitation? Do you wait for full recovery of elbow motion?
No, what I'm doing is I'm integrating it as soon as possible. I already started in the early phase, but then with the brace on, and then in the next phase, when there is confidence, I integrate it without a brace. So as soon as possible, we integrate it first. Of course, without weight, but afterwards you integrate it as long as the patient or the athlete can support it. And as told in the presentation, I always ask to the reaction of the patient, and I look at how he is or she is reacting on the treatment.
Yes, thank you. And you also work with the other arm during your exercises?
I also
in your
work with.
presentation.
Sorry?
You are doing exercises for the other upper limb?
Yes. Of course, the shoulder, as I was telling, the shoulder is really important, but also the trunk and the neck stability is sometimes forgotten. So I start in the early phase with those exercises from the trunk, the neck, and then the shoulder before we can really engage the elbow.
Okay, thank you. It was very interesting.
Thank you.
I have a question from the chat to Adam. We lost the sound while you're having your presentation. Can you stress once again the indication in type A, so isolated coronary fracture, indication for surgery?
Yeah, thanks, Alessandra, and apologies everybody for the loss of audio. There's definitely patients with Wrightington type A fracture dislocation, a PMRI pattern, anteromedial facet fracture. where we can get away with non-surgical treatment. And we've been looking at in our own research group to try and understand the patients where we get away with that non-surgical treatment, and the ones where if you neglect them within 12 months, they'll have osteoarthritis. And what we are finding is that there are some patients with an anteromedial facet fracture in whom the ligaments are intact. The lateral ligament's intact, the posterior band of the medial ligament is intact. And they seem to have congruent joints, and they seem to do well with non-surgical treatment. And then the other group is those in whom the ligaments are torn in association with the bony injury. And then even if they're congruent at the time of initial imaging, then we have a high suspicion of ongoing instability, and will tend to be more interventional in that group. What we don't have is a randomized controlled trial to tell us which ones, whether or not we do need to intervene in those. Do you need to use MRI? You don't. You could use ultrasound. You could do an EUA, as Lee talked about in his talk. But the important thing is we need some way of differentiating those with unstable elbows and those with stable elbows, just as in the simple elbow dislocations.
Thank you, Adam. Lee, do you wanna? What's your opinion about it?
Yeah, I just want to. They're fascinating, the PMRI ones, but that is the one test where I might actually use a clinical test. I said earlier in my talk that most time I'm relying on my imaging, my plain films, my CT scans, my EUA. But I do like that gravity various stress test, just putting their arm, abducting their arm to 90 degrees and just getting them to flex and extend. It's not a very stressful position for the patient generally. And you can, I've had it, it's here, the crepitus of the trochlea rubbing on the anteromedial facet fragment. So that's the one clinical sign I will do. Most of my talk was about simple instability, no bony injury. Okay, so but the one clinical test I like is that moving various stress test.
So you don't make the evaluation under anesthesia; you just feel the sound of the crepitus.
So, again, there's some that are obvious, they need something doing. There's some that are obvious, they don't need something doing. And the ones that are in the middle, you've got to come to an idea. For the PMRI pattern, the anteromedial coronoid, that's one clinical test I like. I don't know, Adam, have you used it?
Yeah, absolutely. I agree, Lee. But the only thing I would say is that we don't know the sensitivity or specificity of that test. So I think it's again, it helps us to build up the picture. But I wouldn't put all of my eggs on that one basket. But I think it's a really useful test and sign, and definitely one I use in my practice.
Dr. Singh?
Yeah, question to Lee. Lee, when you fix the elbow in the simple elbow dislocations, fix the lateral and the medial side, what instructions do you leave for your physiotherapy colleagues?
So firstly, I don't leave theatre until I'm confident that the elbow is safe to move. And the fact that I can then look the patient straight in the eye and say, I know it hurts, but you need to move it. I like the gravity assisted overhead exercises. So I send them to the Best Elbow Stiffness, the Best Elbow website, the great videos. Mm-hmm. And so I just tell them to put into Google 3 words, Best Elbow and Stiffness, and it gives you the overhead rehab protocol. Great videos from Val.
Thanks.
There's a question for the physiotherapist, for Marcos and Tom. Do you use any specific objective testing when returning to sport? Some objective
I might leave this one for Tom. I don't specifically work in a sporting environment, so I'll leave this one for Tom.
I do testing for the return to sport. But it's really sport specific. You do some handheld dynamometers. You can use them to check the balance. But most of the time, I use tests like sport specific movements. So it's not really like you don't have the data, but you look at the reaction of the athletes because like I told in the presentation, every sport has a different outcome, and a different weight and force integration. So what I'm doing is I'm looking for the movement, what he has to support, or what she has to support, and then I do the testing. So, for instance, like with judokas, what I'm working a lot with, I do, for instance, the crab stretch, and we do the front square. It's like really supporting, but turning, like you do like in plank position, and then you do a turning on the elbow. So it's a really stressful test and under compression. So that's a sport-specific test. So that's really important that you look at the sport specificity of the athlete.
Thank you, Tom, for your answer. About the second session, we have a question from the chat for Pieter, Paolo, and Roger. What's your threshold? You are very expert as an elbow arthroscopist, but what's your threshold for managing the PLRI by arthroscopic or open approach? Pieter, Paolo, and Roger, your answer.
Yeah, it depends, first of all, a little bit on your arthroscopic skills, I think. Certainly in the beginning, don't burn yourself, or be prepared to go open if you need it. For me, I look at a couple of things, not only the instability when I evaluate them during surgery, but also I do pre-op MRI. So I look at the tissue quality. If there's a severe retraction of the ligament, in my mind, it doesn't really work to imbricate that. I need some connection up and down. I look at the Bateman score. So if they're really very, very lax, you might need something else than their autologic tissue to stabilize that. And based on those three factors, if there's not preoperative arthrosis, because then again, you might need something else, I go for an arthroscopic treatment. If there's really tissue loss or tissue quality that is bad, I add something biological.
Paolo, you are mute.
So basically, I totally agree with Pieter. I do think that the question should be somehow move it to more than arthroscopic versus open, that I do think is just related to your skills. Eventually, what I can say is that if you're able to eventually open the elbow in the arthroscopic position and finish your operation in that position, you have a step that you can do. So you can eventually evaluate arthroscopically and switch and continue in that position. That's another step. And the other point that maybe I can add is that maybe it's not too much into arthroscopic versus open, but using sutures and materials that are suture related, anchors, whatever, versus using grafts. And my personal feeling is that whenever we use graft because we are orthopedic surgeons, we're very used to use grafts, but probably no less of that material respect to modern tapes, sutures, and all that type of material that we can have. So if we're talking about autologous graft, maybe there is still a space because there is some biology. But if we're talking about allograft, then I do think that modern sutures, tapes play a role. And my threshold is moving upward day after day. So more and more into sutures and tapes.
Roger, what do you think?
Yeah, it's difficult to be the last one because many things have already been said. What I want to add is if I really look at the patient, I don't only look at the MRI or look at what I can do. If I feel that the patient is, for example, non-compliant, or if I know that the patient had tennis elbow with 7 or 8 cortisone injections and then failed surgery, then for me it's open because I want to add some biology, as Paolo already mentioned. if I feel that the patient is going to be compliant and the tissue is good, non-smoker, relatively younger patient, maybe post-traumatic instead of iatrogenic, then I do like Paolo and go more and more arthroscopic. It's not a as already been mentioned before, it's not a clear science. It's more of a feeling when the patient's sitting in front of me.
And we know very little about laxity again. Pieter has been saying that at the beginning and several times during his presentation. We need much more literature about role of pure laxity.
So there are two last questions. Solenn, do you want to make the question for the physiotherapist? You are mute.
Sorry.
Thank you.
So a question for the physiotherapist. In cases of simple elbow dislocation, conservative treatment, how important is to include specific exercises for the unconeus muscle during physiotherapy? Which kind of exercise?
Yeah, I'm happy to take this one. It's a simple answer. You can't isolate anconeus. It's all involved with extension and wrist extension exercises. You can't isolate it.
I totally agree. You have to use the chains.
Thank you to everyone, to all the speakers, moderators, and to the SECEC staff, SECEC and Marie. Before we end, we're going to show a presentation about a couple of things which SECEC is doing. It's welcoming the new junior membership. It's free of cost, and it provides a great scientific educational program which we run on a continuous regular basis. There are future webinars coming up. So this one on the 4th of June is on the transulnar elbow fractures, and we have Dominic Rolou and Professor Sean O'Driscoll. So please do log into that and register into that. And last but not least, our meeting, which is coming on the 2nd to 4th of September. So there is still early bird registration till May the 27th. So please register for the SECEC Congress, and there is special discount for the members if you become a member. All the recording for today will be available, and thank you to everyone, to the speakers and to the participants. Good night, everyone.